So we shall now go on to Dr. ANAGHA HEROOR, who's another very dynamic cataract and refractive surgeon, who's the medical director of Anil Eye Hospital and also member ARC West. And she is going to be talking on a very important topic, small pupil choosing the appropriate procedure, preferred practice guidelines. On to you.
Thank you so much, ma'am. A very warm welcome to
Tamil,
all of you.
can you come and sit here?
And I'd like to thank Chitra ma'am for giving me this opportunity. So I'd be speaking on small pupil management, no financial interest. So when you talk about small pupil, how small is actually a different and very relative, and it all depends on the surgeon's skill, his expertise, the experience that he has gained over the last so many years, the intraoperative situation and the iris tissue properties. So most importantly, in the OPD, we need to look out for these patients, in our routine cataract patients, for the common causes of small pupil. It could be just senile, it could be a diabetic patient, pseudo exfoliation, because there are so many things associated with it. An IFIS patient, so you need to ask for history, a post-uveitis patient, or a patient of ankle closure glaucoma, probably who has been on long-term. So basically the technical challenges of a small pupil surgery is the reduced visibility at every step of the surgery. So you have to be extremely alert in these patients, because at each step there can be a problem and it can end up with a poor visual outcome and an unhappy patient. So we need to fine tune our surgery. So first is the preoperative screening. So when you're looking at these patients, also not only take the medical history, because you can anticipate an IFIS on table, also the detailed ocular history. Check what is the dilated pupillary size. So you need to actually be ready and have your plan B ready with you. You may need to fine tune your technique. Say for example, some kind of pupillary stretching, which may not be recommended in all cases now. You need to fine tune your phaco settings, so reduced vacuum or flow rate, and an optimal use of materials like OVDs and pupillary expanders. So you should have a stepwise approach. So we all begin with the preoperative mydriatics, but there are patients today who are allergic to dilating drops. So what do we do in such cases? So we have the intracameral agents today, for example, the Phenocaine Plus, no financial interest, but it really works superb. And also the optimal use of high molecular weight viscoelastics. So for example, this was a patient who was allergic to dilating drops, and you can see how the pupil nicely expands. It takes around 10 seconds, and then each step of the surgery can be continued with equal ease as if the patient has been dilated with drops. So there's absolutely no issue with it. Now coming to the next step, obviously there are patients who are going to have adhesions or post-uveitis patients, so you need to break this synechiae. This was a patient of trabeculectomy done. There is a PBIA also, and the pupil is mid-dilated. So not in all cases you would definitely go in for a pupillary expander. So this procedure of pupillary stretching was done earlier. Nowadays it's not really recommended so much, but it gives you an adequately sized pupil for all you to go in for the complete phacoemulsification. So the capsular axis should be along the pupillary margin, so you have an adequately sized axis, and be sure to be in the center of the eye, in the central, say 4 mm zone, so that you don't pull on the iris. The moment you touch the iris, it will keep coming into the phaco probe. So you need to be really careful in such cases. So this was the post-op day 1 with excellent results. Coming to IFIS, we all know it's a triad of progressive miosis, iris prolapse, and billowing of the iris. So you need to be extremely careful. So what works and what doesn't? So you can give pre-surgical topical atropine, you can use intracameral epitrate and viscoelastics. Your wound should be really good. If you have a very short wound, the iris will keep prolapsing. Very gentle hydrodissection. Even when you're using a bimanual, see that the irrigation currents are not directed at the pupillary margin. Many times in these cases, you can use iris retractors. One just below the incision also helps, and definitely pupillary expander. So the moment you find on table that the pupil is showing a lot of billowing, go in and put in a pupillary expander. There's no ego in it, because during the rest of the surgical steps, if it comes down, then you are in a soup. What does not work is stopping Flomax, because that doesn't really reverse. Do not do pupillary stretching, no sphincterotomies, and do not overfill the chamber with OVD, because that will only increase the prolapse. You can also use a tri-soft shell technique here. Now coming to the next part, and that is the expanding devices. my threshold of using is quite low, especially in IFS. So pupillary expanding devices, I would be speaking on the iris hooks, the Melugan and the BHEX, though there are a lot of them available, whatever works best in your hands. So this was a patient of pseudo-exfoliation, the two eyes of the same patient, mind you. So the one to the left is where the pupil was fairly well dilated, so I didn't find the need for using a pupillary expander, and one on the right was the other eye where it was slightly borderline, but because it was a pseudo-exfoliation, I went ahead and used an iris retractor. Now in iris hooks, you have to be very careful as to where you take the paracentesis. If it's too high, then it will actually pull the iris or the pupil towards the cornea. If it's too low, then it will actually bunch up the iris towards the edge, and the phaco probe will actually scrape against the iris every time. So you need to be very careful about it. Also, do not pull the iris hooks too far towards the limbus, because that can cause sphincter tears, and then you can have a problem like this. So you need to be very careful, just a very gentle pull on the pupillary margin. Now this was a patient, one-eyed patient, post anti-glaucoma surgery done, very small pupil, and we are using a Melugan ring here. So this works really well. It has a biplanar structure, and there are 4 scrolls with a preloaded one with the hook. So you can easily put each of the scrolls very gently along the pupillary margin, and it works well. It holds the pupil very well throughout the surgery. So this is the preferred expander of choice in many of our cases, especially as it works really well, and removal also is quite easy. Since we are short of time, I'll just rush through. This is the pupillary expander. So you have these alternate flanges with and without the hole above and below the iris. So this was a patient with floppy iris where we are planning a multifocal IOL. So you can see, as I'm putting in the BHEX ring, you can see how the pupil actually comes down. So it is these cases, especially when you're planning a multifocal IOL, the BHEX is very, very gentle, and it has a very thin profile. So it works well, and it keeps the pupil well dilated. So you use a 23 gauge microforceps to hold on to it, and the flanges on the side, you can use the forceps and the Sinskey hook from the side ports. So you get a nice 5.5 millimeter opening, and you can continue all the steps. The removal is also very easy, and once. So this was the post-op day 1. As you can see, the pupil is really well centered and round. This was a very interesting case. I think, ma'am, I'll just rush through because time is up.
Yeah.
Yes. So just going to the end, if you compare Melugan ring with BHEX, it's not just the cost that is different, but because the BHEX is jointless and uniplanar, it works really well, but it takes a little learning to it. So once you do a few cases, you will really do well. So just to conclude, all these pupillary expanders and cases of small pupil, you need to really plan your surgery in advance to get very good visual outcomes. Thank you so much for your kind attention.
Thank you very much, Anagha. That was a very wonderfully discussed topic and meant to be done in 6 minutes. While Dr. Mahipal connects his slides, I would like to take 1 or 2 questions with Dr. Basin, and I would take your questions too. In a small pupil, when would you think you would want to use a BHEX, a Melugan, or when you feel iris hooks is the only answer?
Iris hooks is the only answer.
It's a better answer. No, it's not the only answer. It's a better choice. There's some time when you think it's better to do an iris hook. I may be wrong. I'm thinking of something and I framed this question. But would you feel any of them you would take in whichever is there in your hand for all situations? I want my audience to have the different opinions on this. I believe that if it is a floppy iris, I would feel more comfortable. I feel using iris hook is actually the best way to go with a floppy iris. Otherwise, I would mind a Melugan's ring, but with the BHEX, I feel that the iris continues to prolapse.
Yeah,
with
but Melugan, you are very much safer, ma'am.
Yeah,
very
that's
much
the difference I want to ask.
Melugan is, I think we can use whatever
Iris.
is
Ma'am,
available.
I've used multiple occasions BHEX, and I'm very happy. But it's not just the pupillary expander. It's also the bottle height. It's the calibrated side ports. It's how you manage and you not touch the pupil too much. So there are so many other factors. I think any pupillary expander which works well in your hands
Yeah, but I felt BX would not be the best for floppy iris. You're
Yeah,
not
for
so sure?
floppy, I believe that yes, the original version of Maligan is better even than the 2.0 version.
Yeah.
And of course, it's better than BX because BX is very thin and flimsy and
Yes.
it tends to, move along with the iris.
Yes.
That's what I felt.
Yes.
And only one condition, ma'am, as you said, where I'd like to use iris hooks is very shallow anterior chamber, where it's difficult to put Maligan ring or any expander.
What I'm going to be doing is, I think Dr. Mahipal is in a hurry to leave. Body language is saying that. So let's hear him talk